Hello and welcome back to MedSynapse podcast, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today we have incredible guest with us, Dr. Vikas Kumar Pandey. He's a renowned oncologist with extensive experience in management of genitourinary cancers. He's the consultant radiation oncologist in Manipal Hospital, Delhi. His work has been pivotal in advancing personalized treatment strategies. Let's start with our podcast with first question. Our listeners are eager to hear your insight on muscle invasive bladder cancer. Recent trials have shown varying complete response rate with trimodality therapy. How do you approach patient selection for bladder preservation and what molecular marker influence your decision making process?
Thank you so much for having me here. What a great podcast. So, I'm going to talk about bladder preservation and the trimodality therapy. And I just start with a case which I saw last week in my OPD. A 62 years old male was referred by a urologist with the first occurrence of 4 centimeter bladder tumor located in the posterior wall. It's muscle invasive, so clinically T2 disease. The urologist was able to achieve complete resection. There was no hydronephrosis, no lymphadenopathy, good renal function. The question is the patient right candidate for bladder preservation? If so, with what strategy? I would argue this is a perfect patient for chemoradiation and trimodality therapy. Then you have to ask yourself, why are these patients not offered the option as much as perhaps they should? So, just to keep those things in the mind, I would like to discuss a few points. And my first point is that organ preservation is a commonplace in oncology these days. Organ preservation is being practiced in breast cancer, anal carcinomas, limb sparing, extremity sarcomas, laryngeal tumors. And the question is, why isn't bladder, more firmly on that list necessarily? We also know the morbidity of radical cystectomy has been well documented, and it's a great surgery, and the patients can do very well, but it is certainly life altering. There's a lot of complication associated with it. A quarter of these patients are going to be readmitted because of these complications, and their measurable 90-day perioperative mortality typically is of 2 to 3% range. And this data is from high volume centers like MSKCC. The other point is that cystectomy, if it is a gold standard, is not actually performed in about 50% of the patients nationwide. The median age of bladder cancer is 63 years, and 50% of the patients are not getting radical cystectomy. And I'll tell you, the trimodality therapy or chemoradiation is not filling the gap currently. It may add to another 10%. So there is a huge unmet need. There's an under-reserved population, and trimodality therapy can help fill that gap. It's important to engage our urologic surgeons into this treatment paradigm and remind everybody that this is still a surgical approach. A maximum TURBT is instrumental to success. These patients go through chemoradiation most of the times down the left path, there where they get full dose of chemoradiation and a cystoscopic assessment of their treatment response is done. If there is a complete response, lifelong cystoscopic surveillance is advised. If there is a recurrence on follow-up, or if there is an incomplete response, they perhaps go for salvage cystectomy. And that needed these days is about 10 to 15% of the patients. Now, if we look at the large series of data which we have on trimodality therapy at present, the complete response rates these days to chemoradiation are in the range of 85 to 90%, which is pretty darn good. Our 5 years disease specific survival approaches 85% as well. that would compete very favorably against select cystectomy series. Cystectomy series, mind you, that are looking at those perfect T2 small solitary tumors. These cystectomy series would not have better results than this. In addition, less than 15% of the patients these days are needing salvage cystectomy, and these are the data which I'm presenting to you are from large centers. And so keep that number 10 to 15% in mind because that keeps coming out in series after series now for those patients who need salvage cystectomy. Selection is important. Yes, T2 does better than T3 and T4 if you don't have hydronephrosis, if you don't have carcinoma in situ, if you are able to get a complete TURBT, you are going to do better. So that's choosing, the perfect patient with those selection factors. Does it mean that the patient who has a T3 tumor is with incomplete TURBT can't get bladder preservation? No, they may do worse, but in fact, they will do worse with surgery as well. Now, there are some patients I would suggest, and I would raise a caution before offering them a trimodality therapy. And I usually gear these patients more towards cystectomy based approach. Example, if a patient has inability to have a complete resection, presence of hydronephrosis, large tumor burden, extensive diffuse multifocal carcinoma in situ, upper tract involvement, cancer in a diverticulum, or prostatic involvement. These cases, I usually think more about neoadjuvant chemotherapy followed by surgery. If they are not candidates for surgical approach, certainly RT can be considered, but just a word of caution. One important concern during patient selection is histology. Most of the tumors which we see are urothelial carcinomas, but at times there can be mixed features of squamous cell in the urothelial background. I think these cases are actually fine for chemoradiation. However, if you have more aggressive variant or subtype histologies like micropapillary, plasmacytoid, or sarcomatoid, I would raise a little more caution for chemoradiation. And again, I gear these patients towards surgical approach. Now comes the age-old question. How do we do against cystectomy? We do not have a randomized trial which has a head-on comparison between cystectomy and chemoradiation. It was attempted in UK, but it failed to occur because most of the patients didn't want cystectomy as it turned out, and there is no trial currently planned. So we have to look at the best data available. And the best data available as of now came in summer of 2023 by Zlota et al. And in that study, the predefined endpoint was metastatic free survival, and there was absolutely no difference. There was no difference in the regional failure free survival. And if you look at the cystectomy patients, if in that particular study, if they had a T3 disease or if they had hydronephrosis, they did worse. Okay, that's a good reality check. So if these patients are doing worse with surgery too, and there is no subset that did better with surgery. So if we looked at the T3 patients or only those patients with hydronephrosis, they did similarly between the chemoradiation, trimodality, and cystectomy. Now this has a good little tidbits to it. Number one, 13% of the patients treated with trimodality therapy required a salvage cystectomy. And again, remember, it's the number I have told you, 10 to 15%. It keeps coming again and again. 20% of the patients who had trimodality therapy developed a non-muscle invasive recurrence and on follow-up. So you got to follow these patients lifelong. Then there was an analysis by which was done in Toronto, and we looked at those patients who required salvage cystectomy because they had muscle invasive recurrence in the bladder compared to those patients who did not needed a salvage cystectomy because they never had a recurrence and their long-term survival was same. So what does this mean? It means that salvage cystectomy is curative for these patients. And in those 10 to 15% that need it, it is a curative options. There is a second chance of cure. And indeed, the salvage cystectomy morbidity is acceptable. I don't know if everybody knows this, but if you look at NCCN guidelines for stage 2 and 3A bladder cancer, chemoradiation is category 1 recommendation. The only other category 1 recommendation is neoadjuvant chemotherapy followed by cystectomy. So, cystectomy on its own is not a category 1 recommendation. All right. So, we have a high level of evidence to support TMT, and it's actually been recognized in the guidelines. And I think I have been a little bit more elaborate on this. I will come to the second part of the question about the biomarkers and biomarker driven management of muscle invasive disease. Are there biomarkers that can help inform the treatment strategies? Well, we have a long list of it, which are potential biomarkers. Most of them are prognostic, some are predictive, all of them require prospective validation. There's MRE11, which is involved in DNA double strand break. And if you have high expression of that protein, you do better with chemoradiation. And there's no difference with cystectomy. So this implies predictive marker, right? You do better with one treatment. And we have looked into the NRG studies, and it has shown that MRE11 high expression is prognostic and it improves disease-specific survival. So that's an interesting biomarker. Some recent sort of whole exome sequencing work has shown that ERCC2 may be associated with improved survival. Now, ERCC2 mutations come in a lot of things. You can do better with chemotherapy, neoadjuvant chemotherapy, if you are having cystectomy with ERCC2 mutations. So, another interesting one. Immunotherapy has exploded in bladder tumors, especially in advanced disease. But also, some data is present in adjuvant settings after cystectomy and even in non-muscle invasive diseases, but not yet validated in tri-modality therapy. And the question is, if you add immunotherapy to this milieu to tip the balance in the favor of anti-tumor immune response, what is the data? And there is a big trial ongoing partnered by SWAG and NRG Group looking at chemoradiation plus atezolizumab for 9 cycles, and it just completed accrual last year. The early safety analysis seems to be safe and acceptable. So, in conclusion, in 2025, patients should be offered trimodality therapy. There are many muscle invasive patients that are not getting curative treatment nationally. There is an undertreated, under-reserved population. It is supported by numerous guidelines like NCCN. Trimodality therapy is a category 1 recommendation. In clinically matched patients, survival seems to be comparable to cystectomy, and that's the Lancet Oncology paper. More than 85% of these patients are gonna keep their bladder, and their long-term quality of life is good. If it is not a non-surgical approach, and you got to remind your urologist colleagues of that. Maximum TURBT and salvage cystectomy are key to the success of this paradigm. There are many opportunities to improve the clinical staging, and I always recommend use MRI for the clinical staging. Delivery of radiation, and we are talking about image guidance and adaptive planning and systemic therapy, and maybe addition of immunotherapy into the paradigm. And we got to keep validating the biomarkers in prospective cohorts to help guide personalized treatment selection. So remember that safeguarding the autonomy of patients with bladder cancer is key, and informed decision making is the key. And that means a multidisciplinary approach, working with your urologist and working with your medical oncologist.
Our second question focuses on stereotactic ablative radiotherapy in primary renal cell carcinoma. What data support it uses usually?
So I think I can't discount the fact that surgery still remains the standard of care for patients with non-metastatic primary renal cell carcinoma. And we are seeing a lot of renal cell carcinoma patients these days because of an increased frequency of abdominal imaging that's coming up for medical conditions other than tumors. And you will see a patient in the hospital who is elderly, who has come for abdominal pain, and they will get a CT scan, and then they will see a renal mass. And so these patients are coming to the oncology clinics, especially referred to urologists. And these patients should be discussed in a multidisciplinary form. And I think we have to be on the table as a radiation oncologist to discuss with our urology colleagues in terms of what is the best management of these patients. But I think in general that surgery still remains the standard of care and nephron sparing approaches are the most common used ones. But there are many patients who are not eligible for surgery because of either chronic renal dysfunction or significant friability or poor performance status or other comorbidities. And so, while there are alternatives that are available to them, which includes ablation, which has a good local control, these invasive techniques are limited by the tumor size, ideally less than 3 centimeters, and the location, that is, they require more than 1 centimeter distance to adjacent critical anatomic structures such as collecting system or vasculature. SBRT or SABRE overcomes the limitations of size, precarious anatomical locations, or growth patterns faced by ablative procedures with promising evidence of renal cell carcinoma tumors that are more than 3 to 4 centimeters, endophytic, and or centrally located. And these are supported by two big trials. The first trial was done by Dr. Shankar Shiva and with a group called IROC. So IROC is the International Radiosurgery Consortium for Kidney Cancer. They pooled the data together on the results of individual kind of retrospective studies. And just to highlight the kind of patient population in IROC, they tended to be a more elderly population and had tumor sizes that was roughly 4 to 5 centimeters on average and had fairly mild to moderate renal dysfunctions. And they were treated with ablative radiotherapy doses of 30 grays on average, either singles or 3 to 5 fractions. And with a median follow of 5 years now from the IROC data, it shows that very good cancer control results. So the failure results are as low as 6%. The cancer specific survival is 92% at 5 years. And now the progression free survival is 65%. But thinking about the population of these patients, about 3 quarters of them were medically inoperable. So, in general, most patients were dying of other comorbidities. And that kind gets counted as event in this analysis. But the distant failure was roughly around 11%. So, fairly good results for a pooled analysis of primary kidney SABRE. Now, the next question you may ask is, do we have any other randomized trial which supports use of SABRE? Well, Dr. Shankar led this again, and this kind is hot from the press in Lancet Oncology last year, the results of Fast Track 2 trial. And this is even more impressive than IROC data. He actually showed 100% local control rates at a median follow of 4 years and a cancer-specific survival of 100% as well. So showing that even it kind of mirrored what we saw from IROC data. And these datas If you see from the fast track 2 data, the adverse events again, the rates were fairly low with no grade 4 or 5 toxicity seen in the patients. So this is very, very encouraging. And this is what has really helped to build the foundation of trying to create a new indication for radiation therapy. And so we are really excited about this data and the IROC data.
That was a very well put together answer, Dr. Vikas. Let's move on to the next question. When considering stereotactic ablative radiotherapy for renal cell carcinoma, how do tumor size, location, histological feature guides your treatment planning, and what technical consideration are crucial for optimal outcomes?
Coming to the key points that decides how the tumor factors guide SABR planning for renal cell carcinoma. So the first and the foremost thing is the tumor size. Smaller tumors, less than 4 centimeters, are typically treated with single fractionation if there is no adjacent bowel or vasculature nearby. Larger tumors, more than 4 centimeters, I would treat with multifractionated approach and careful monitoring of the kidney functions. Now, tumor locations is also important. A tumor near the renal, pelvis, or the major vessels may require more precise targeting to minimize the damage to the surrounding structures. Now, one question which always comes in mind is that what about the tumors which are adjacent to the renal hilum? Because that's one thing that people are concerned about, whether or not there's going to be a damage to urothelial tissues there. And so we have a data from Montreal addressing this region treated with SABR. Even though this study is a small series, but what's really important about this is that these patients had stable chronic kidney disease with no worsening of their function, no stenosis of the collecting system, and no patient requiring nephrostomy tubes. And actually, good responses as well. But really, this proof of the concept that if the tumor is abutting or invading the renal hilum, it's still treatable with SABR. Next is the histological features. Now, if we look into the data from IROC or Fast Track 2, some of them had non-clear cell histology, which we are not sure whether or not there's actually a difference in the outcomes. The numbers are so small, you can't really have a lot of granularity to this data. But interestingly, there was some difference, and so maybe there is an effect on the non-clear cell histology with SBRT. We are not 100% sure about that though. So aggressive histologies, subtypes of renal cell carcinoma like sarcomatoid carcinomas may necessitate aggressive radiation regimes. Tumor grades can influence the treatment planning, with high-grade tumors potentially requiring higher doses. Now, coming to the second part of your question, what are the technical considerations for optimal SBRT delivery? So, obviously, the first foremost thing before planning, I would require an advanced imaging. A high-quality imaging modalities like CT and an MRI are essential for accurate tumor delineation and target volume definition. I always stress MRI should always be done in all the bladder cancers. Now, for target volume delineation, careful consideration of the planning target volume, that is a PTV, should be done to balance the tumor control and minimizing the normal healthy tissues, and incorporating margins for potential tumor motion and setup uncertainties. And that comes to a very important point for your kidney SABR, respiratory management. Techniques like deep inspiratory breath hold techniques or respiratory gating may be necessary to minimize the motion during the treatment. What about the dose fractionation? So choosing the optimal number of fractions on the tumor is generally based on tumor size and the patient factors and what are the adjacent structures which is present near the tumor. Higher doses per fraction can be given for small tumors, whereas large tumors, I would prefer to go for a fractionated SBRT approach. In general, the patients who generally are selected for single fractions tend to be a bit younger, have a better performance status, and have small tumors with good renal functions. And that comes to an important point, renal function monitoring. Assess kidney function before, during, and after treatment to monitor the potential decline. If we look into the IROC data, it showed that at about 5 years, there was an initial drop in the renal function to 10 points below the initial EGFR, and it roughly goes down to 13 to 14 points. And that's what we see in the clinics. But with surgery, depending on the type of the surgery, what you are doing, you can get significant changes in the renal function. And if they do a complete nephrectomy, you are basically cutting half of the function. So I would argue SABRE has a very comparable renal function changes, particularly as we treat larger and larger tumor masses. And most importantly, and finally, a multidisciplinary approach, close collaboration between a radiation oncologist, urologist, and radiologist to optimize the treatment planning and patient selection. So, when we look at the management options for primary renal cell carcinomas, active surveillance is obviously considered sometimes, and that's a standard, but there's a limitation to that, and many of the patients will progress. Nephrectomy is certainly an option, but again, there are limitations to that as well. The thermal ablation is an option if you have a small size tumor and a proper location for it. But I think SBRT is the one which has got a lot of potential because it can be offered for any tumor size, any location, and it can be thought about. Now, if we look into the guidelines, NCCN 2024 guidelines actually call SABRE an ablative therapy, and it's a part of algorithm now. So that's great that there's now been a little bit more push, but the European guidelines still do not recognize SABRE, and it's just at the footnote in the bottom. So we still need to engage our colleagues in urology to try and push SABRE forward into the guidelines now that we have good prospective data and lot of long-term data on toxicity. I think one of the reasons why urologists are reluctant is because we are not really sure about how to define the local control. There may be pseudoprogression post-SABRE, and so using RECIST may not necessarily be a best marker or indicator of response post-SABRE. A lot of work is going on this, and hopefully we'll be able to address this issue soon and convince our urologist colleagues.
Thank you, Dr. Pandey, for sharing your expertise and insight with us today. It's been an enlightening conversation, and I'm sure our audience will has gained a lot of insight from it. And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussions and contribute to the ongoing evolution of healthcare. So until next time, stay healthy, take care, bye bye.